Hello? Hello? Is this is it is the camera working? Hi Jan. Jan, is the camera working? Can you see me? Is it working? Oh, you can. Okay. I've got a black screen, but anyway, never mind. Right, hi. Well, thanks for thanks for coming, Jan. Nice to see you. So this is the Q&A, live Q&A, and I'm hoping my questions are going to come up on the screen. Anyway. Oh, that came up. Please comment and share. Okay, that is working. Right. So good. If anyone's got any questions, please ask me them. But I have got quite, because I wasn't here last week because it was holiday time, wasn't it? It was Easter, so I wasn't here last week. So we've got quite a few questions going on. Hi Zoe, good. Yeah, right. We've got this going on now. It's all looking like it's working properly. That's good. So right, kicking straight off with this question right here, which says pros and cons of using the areolar incision to put implants in. So this is the thing about a lot of plastic surgery is that there's no right or wrong, and you will find that some people will use the areolar incision, which is a little U at the lower border of the areola. Some people will use the armpit incision, transaxillary, and some people use the inframammary incision. And you'll find that some surgeons will use a particular incision, and that might be due to training, that might be due to experience, to what they're comfortable with and what they felt is to be best. And one of the issues is because there are surgeons that use all of them, you can't really say that one is best, because otherwise why do other surgeons use the others? So you've got to be a bit wary about someone saying this is the best way to do it, because you think, well, why did the other guys not do it that way if it's not the best way of doing it? So there is no one best way of doing it, and all ways are acceptable. But what I would say is you need to find someone who, if you've got a preference for a particular incision, find someone who does it regularly and is comfortable with it. I have done quite a lot of stuff through the infraareolar incision. I don't routinely put implants through that incision, and I don't use that incision for putting implants in personally. It seems to be popular in America. Don't know why. There might be a reason why, but in the UK it's not very popular, the infraareolar incision, at least for putting implants in. And I'll tell you the pros and cons as I see them, but I'll preface that with saying that I don't use it much, so maybe someone who uses it more will be a bit more pro about it than me. I tend to use the inframammary incision. So the pros and cons. The pros of the incision is when it heals well, it heals beautifully, and the reason that I know that is because I use it routinely for men. When I do a gynecomastia, I do the same incision. It's like a U shape at the bottom of the areola, and when it heals, one of my blog posts is something like invisible scarring from gynecomastia, or gynecomastia without any scarring, because when you look at it, you actually can't see any scarring. Now there is scarring, there is that infraareolar incision, but you really can't see it. It heals beautifully. So the pro of it is a beautiful scar when it heals well, and that is a massive pro. That is a big pro. The cons are that if it doesn't heal well, then you're in trouble because it's on the front, sort of in the nipple. Your nipple's on the front of the breast. Whereas if you have an inframammary or an axillary scar, if it's maybe doesn't heal quite so well, it's a bit more hidden, especially the axillary one. And the other cons for me is that because you're making a U-shaped incision of the areola, you are potentially cutting some nerves to the areola. So often after breast augmentation, people have funny feelings and funny sensations in their breast and in their nipple. Now, if you've used an inframammary incision, you haven't actually cut through any breast tissue. You've gone inframammary and you've just lifted the breast tissue up and put the implant underneath it. So often the sensation will come back to life because you haven't cut any nerves. Now, you're more likely to cut some nerves going to the nipple when you do an infraareolar incision. So you might have more potential problems with sensation of the nipple after an infraareolar incision. And also you're cutting through the gland of the breast. You have to cut through the gland of the breast in order to put the implant in. So you're cutting through more glandular tissue. So I worry a little bit about infection and things like that. It's probably not statistically significant. I don't know studies that have looked at it, but you do have to cut through more breast to put it in through an infraareolar incision. But the main issues are the two things that I would worry about is that if you don't get a good scar, it's on the front. It's hard to hide that incision, and it's more potential for nipple sensation issues. So that's why I don't do it, and I use an inframammary scar, and I've got good experience with that. But it's it's a perfectly reasonable way to do it. And if you want it done that way, then you can have it done that way, but find someone who's familiar with it and comfortable with doing it that way. And it's not too bad technically, actually. And if you're doing something to the nipple anyway, you can go. Actually, that's a question. I said I was going to ask that question a while ago. Someone wanted an areola reduction. Yeah, I said I'd talk about this. Yeah, someone wanted an areola reduction and breast implants. And I'm sure I said I'd talk about this on here. Can you use the same incision was the question. BBA and areola reduction. The problem with these questions often is that it's sort of my view, and it sort of depends on your surgeon. So I can give you my view on it. I'm sure that was a question I said. My view on that, which is a similar sort of thing. So although tips it a little bit more in towards having it through an infraareolar incision is the only incision you're going to have when putting breast implants in. If you're having an areola reduction anyway, so your areola is too big, so there's going to be a scar around the areola anyway, this patient was saying, can't you just put the implants in through the areolar incision, and then why make an extra incision? And you can. When I've done it, and that's something for me, I talked to the patient about it. Again, pros and cons. And it was probably God knows when it was, probably a year, maybe 2 years ago, when I did one, and I actually used two separate incisions. I actually used a separate inframammary incision just because I didn't want to cut through the breast tissue. And when you do an areola reduction, you're only cutting skin out. So, and the patient was fine with that and was happy with that. And to be honest with you, the inframammary incision usually heals so well, it's not a problem. So I felt more comfortable doing it under two incisions in that case, but I talked it through with the patient. And if you felt strongly that you wanted to through that one incision, let's say talk to your surgeon about it, and they might be comfortable putting the implants in through the areola reduction scar, so you don't get an extra scar. But as I say, there is slightly more risk of sensation to the areola problems and slightly more, cutting through the gland, a bit more dissection. So it's a balance, but you can technically do it. Oh God, we've got some stuff going on here. Denis, we've done that. Jan's done that. Zoe says hi. Holly, hi. We've got some highs. Is there a size issue with impacts? Is there a size issue with impacts? Elaine, size issue with impacts. Is that implants? Size issue with implants? Is there a size issue with implants? What does that mean? I think there is a limitation to the size of implants you can use based on the width of your chest. That's the main thing that determines the size of the implants. Get back to me if you want. Oh God, what's going on here now? I've got to scroll. Oh, implied it. Good evening. See you tomorrow. Am I seeing you tomorrow, Denise? Looking forward to it very much, and I've been looking forward to it for a long time. So I'm looking forward to seeing you tomorrow, Denise. Implants. Okay, size issue with implants. What do you mean size issue? So the main thing with implants, my trident approach, Elaine, you seen it? Another blog post there. Is number one thing is width, and then shape and profile, and then that gives you the volume. So that's how I tend to measure people for implants. So the people focus very much on the size. I focus on the width. You don't really want to go outside the width of your breast. So you are limited. Everyone is limited to the size of implant they can have based on the width of their breast. Some people do go crazy and go outside the width of their breast, but I don't think that looks good, and it risks web between the breasts in mastia. It risks hitting your arm when you're walking and stuff like that. So there are risks with going too wide. So it's width that's the problem, more than volume. It's width. Okay, thanks, Elaine. Yeah, so the width is crucial. So how does body tight lipo tighten the skin? How effective is it? Again, disclaimer: I don't do body tight lipo, but in general terms, this sort of thing works by. So basically, there are different ways that you can tighten the skin, and these sorts of treatments say that they tighten the skin by delivering energy to the skin. So bodytite is like it's radio frequency. I think it's delivering energy to the skin, and that energy is said to heat up the skin, and basically you can heat it or cool it, damage it somehow, and it says that it forms some degree of skin retraction by delivering energy to the skin, and that's how they say that it does it. The radio frequency delivers energy to the skin and causes skin tightening. My main concern with it, and it's like I've just done a blog post about fat freezing. Does the fat freezing work? My main concern with it, that's on my blog. Visit my blog, standardplasticsurgery.com/news, I think it is. Anyway, main concern with it is that I think it does work. But it's subtle. That's the problem with it. And it's never going to be as good as cutting the skin out. I mean, like for instance, body tight, the areas where you want to sort of tighten the skin, things like the tummy, and it's never going to be as good as a tummy tuck. But I think it does have an effect. I do think it does have an effect. Well, I don't know about bodytite. I've never used bodytite, but radio frequency I think does have an effect and does have a tightening. But it's subtle, and you have to be prepared for subtle. And the problem I've got with it at the moment with a lot of these treatments is they're quite expensive. And I've got a worry about people not being happy if they're paying a lot of money for something and not getting a really good result. So that's my issue with it. But if you're prepared to pay and be happy with a sort of subtle result, or if you can see some good result, impressive results, then I think it's good. So that's where I am. I'm a bit cautious about embracing it myself, because I worry that we're going to get people who are annoyed with us because we haven't given them a great result and they paid loads of money. I think you can give an okay result if you don't charge that much. But I think if you're charging the amount that, because the problem is these machines cost a lot of money, these machines that deliver radio frequency and what have you. So that's my problem with it at the moment. And that's why I haven't really embraced it, because it's something that I am worried about people not being happy. I think with surgery, I can confidently say to people, you are going to get a result. You're going to get a result. You're not going to think, hold on a minute, I don't feel like I've had anything done. That doesn't tend to happen when you do surgery on people. And we'll always try and get really happy patients, and we really want a happy patient, and that's what has led me to be a bit worried about embracing these technologies, because I don't know. So I'm worried about that, because they are quite expensive. But I think they do work. I think they do work from what I've seen of them. I think they do work, but it's just a bit too subtle for me. And it's all about patient selection and being prepared for the a subtle result at that price. And if you're happy with that, go for it. But just be worried if they're going to say, yeah, you're going to be great. You don't need a tummy tuck. Have a body tight thing. If you only got a little bit of spare skin, it might work. Joshua, hi. Nice to see you here this evening. Jane, double Jane squared. How there? Oh, hi there. Would you recommend liposuction on the upper arm? Some surgeons say it's fine, and others say they don't do the upper arms, but I have never had an explanation. Why not? Well, it's the same thing, Jane. The problem is just sort of technically speaking, the elbow down is the forearm and the elbow up is the arm. So it's not really upper arm, it's just arm. A bit like the hip to the knee is the thigh and the knee down is leg. Anyway, so let's clear that up. So on the arms, the worry is the skin, Jane, and the skin on the arm doesn't retract so well. And so the worry is if you do lipo on areas like the tummy, like the arms, which have got skin as well as fat, If you do lipo and you don't do anything to the skin, you get even more hanging skin because you've emptied the skin even more, and you can accentuate the defect. That's the reason that people worry about doing. Me, I worry about doing lipo on arms and tummies, because if the skin doesn't recoil, you can accentuate the defect and give more redundant skin and make the problem look worse. So you need to have some degree of skin retraction, which is why things like bodytite and Vaser and all these stuff which they report to deliver some energy, which reports to cause some skin retraction. It's why they exist, because it's a really important thing. If you know, if you could get some degree of skin retraction as well as removing the fat, then that is what you really want. So that's why some surgeons worry about doing it, myself included. If you've got a little bit of fat there, then yeah, maybe lipo will help. The problem with lipo is it's quite expensive, and if you've got a lot, then I would worry that you'd just empty the fat and you'd have the skin hanging. Look at it in your own eyes, just think, would that skin retract, you know? So that's the reason why lipo of the upper arms, I've said it myself now, of the arms is a dubious point. I'm sorry no one's explained that to you, but that's the explanation for that one. Kaylee Louise, how do I know if my implants are the best size for me? Should my breast still sag when I bend over after having uplifted implants in Feb this year? Well, your breasts move, Kaylee. I mean, sag's a bit of a strong word. So sag to me suggests what they look like when you're erect, when you're standing up normally, or sitting normally. I think when you bend over, I always get a bit worried when patients often come and say, look, I'm not happy about this. Look, when I bend over, when I get in this angle, look at this, it doesn't look right. I'm like, you've got to get it looking right when you're standing up straight, normal. If you get it looking right when you're in some funny bent over position, it might be that when you stand up straight, it doesn't look right. And it only looks right when you bend over, you know. So you want it looking right when you're standing up straight. So if you're bending over, I think breasts do hang a bit when they're bending over. You know, you're trying to make it look normal, really. I mean, yeah, I'm talking about my supernatural breast augmentation. People want to look better than normal, but you know, basically, you want a breast to look normal. You don't want it to look weird. So, normally breasts do move, and if you bend forward, especially if you've got large breasts, if you know, whether it be natural or with implants or a bit of both, you know, they will tend to, you know, maybe move or sag. But and how do you know if they're the best size for you, Kaylee? Well, you know that. Only you know that, Kaylee. We can't tell you whether they're the best size. We can tell you whether they're a good width for you, but you've got to match the width with the profile, and the shape. And you know, it's always a bit of a worry saying, are they the best fit? Well, are you happy with your result? That's the, which is the fact that you're putting this on means maybe you're not so happy with your result. So, you know, go back and see a surgeon is my advice there. If it's me, come back and see me. I don't know, is it me? But yeah, I mean, I think that you need to discuss this with your surgeon, because you're obviously not happy by the fact that you've asked the question. But in itself, I don't think it's unreasonable that your breast is sort of moving when you bend forward and things. It's really what they look like when you're standing, when you're sort of erect and standing up, and hopefully they're sort of a bit more pert than they were before with a breast lift and implants, because that's the idea of the surgery. So we're going to, Elaine's coming in with one here. Elaine, question about hips and thighs. Following a tummy tuck, I'm looking at a thigh lift, but I also left with large love handles because I didn't opt for lipo. I can't stand saggy skin. How could I possibly look at combining the two issues? Right, hips. Question about hips and thighs following a tummy tuck. I'm looking at a thigh lift. Yeah, of course you can. Of course you can do that, Elaine. Yeah. So basically, this is the problem with the tummy tuck. A tummy tuck, often your mind and your goals are addressed around the middle bit, the tummy tuck, and certainly value for money. That is where the tummy tuck. That is where the value for money is. The tummy tuck. It is quite a lot more expensive when you do combine it with liposuction, and liposuction addresses the sides, these sort of love handles. But the problem is when you've had that bit removed, often it can be a bit more obvious. The love handles can be a bit more obvious. And people say, what have you done? You put these there. And you're like, I haven't put them there. They were there already. But now the tummy tuck is done, they can look more obvious. And that is often a problem. But liposuction responds well to those areas. It's not so good for the central tummy, but it is good for the sides from the hips. And so liposuction is good for that. And if you want a thigh lift, you can have a thigh lift with liposuction to your hips, to your love handles. That's absolutely totally reasonable. How could I? That's fine. Um, that's reasonable. Reasonable that is, Elaine. Yeah, easy. Well, not easy, but yeah. On the side of lipo, Jan, straight in. Subject of lipo in general. Would lipo on the upper abdomen ruin FDL results 5 months post-op but still have a handful of fat there? No, Jan. That would be absolutely totally reasonable. It's often the way that you have a bit of fullness there, and we try not to do liposuction to that area at the time of the abdominoplasty, and so we normally wait at least minimum 3, ideally 6, to be honest with you, ideally 12. 5 months is sort of, is okay, but it is quite soon after the surgery. If you can wait a bit longer, because there might be a bit of swelling, stuff like that, there might get a bit better. But certainly it's perfectly reasonable to do lipo to the upper abdomen. It won't ruin your results. It'll make them better if you've got some fullness in your upper abdomen. It's not uncommon to need, well, it's not that common, but you might need a bit of lipo to the upper abdomen after a tummy tuck or a fleur-de-lis. Presumably have massive weight loss for a fleur-de-lis. So yeah, that'd be perfectly reasonable. 5 months is sort of okay, but again, speak to your surgeon. But yeah, 5 months is sort of 6 to 12 would probably be better, just to wait everything to properly settle down. But depends on how bad it is. We've got a double thank you, Kaylee and Elaine. Double thank you, thanking you for asking questions, and Jan and everyone else, Jane, and yeah. I've got a question here from the bank. Pulling in the bank here. Hi, I have suffered with capsular contracture on 2 occasions and will probably need to replace my current implants very soon as I'm starting to experience pain. Apart from removing and replacing the implant, are there any other options that I could consider to mitigate the risk of suffering from capsular contracture? Again, I already have the polyurethane implants, but this did not resolve the problem. Right. That's an interesting question, isn't it? Capsular contracture goes through a sequence. It's a progressive condition. It tends to get worse. And it starts off by being able to feel the implant, but you can't see anything. Then as it gradually hardens more, you start to see the implant. It looks like a sort of golf ball, not a golf ball, cricket ball. Anyway, big, like a ball. So it looks like a ball, looks like a sphere. So it can look like rounded, and then it gets painful. And it normally goes in that sequence. So I'm a bit like thinking, hold on a minute, you're saying you got pain. Are they hard as well? So if they're not hard and you just got pain, I'll be thinking, hold on a minute, is this capsular contracture? Particularly since you've got polyurethane implants, because as you said, polyurethane implants got a low rate of capsular contracture. And also polyurethane implants can be a bit uncomfortable. You can feel the edges. They do have a much more of a settling in period. How long have these been in? Doesn't say. It can take a year, maybe even more, for polyurethane implants to settle. They can take a while. I have had one patient who I have had to remove the implants because she had pain. It wasn't capsular contracture, she had pain with polyurethane implants. Sample size of 1, I think polyurethane implants are good, but this happened to one patient of mine, and it's a bit of a worry. And the other thing that worried me was, what if the pain's not caused by the implants? In that case, I did take the implants out, pain was solved. So thank goodness, because it would be terrible to take the implants out and the pain not solved. But and I said to her, it's not common for the implants to cause pain, but clearly they can, because this patient had it. So it might not be capsular contracture. It might be the implants. It might be the fact that the tissue goes into the implants, and that might be causing the pain and the discomfort. So that's the first thing I'd say. I'd say that it might not be capsular contracture if your presenting complaint is pain. Usually pain is an end stage complaint after the hardness and they feel like rocks really when it gets uncomfortable with the pain. But apart from removing and replacing the implants, are there any other options I can consider to mitigate the risk of suffering capsular contracture? Not really. I'll talk in a minute about some drug that someone mentioned the other day, but it's not really something I know much about. But not really, no. How do you stop capsular contracture? I mean, it's a study which said that if you do a lot of horse riding and running and things, that the sort of constant micro trauma can cause a bit of bleeding around the implants and might accelerate capsular contracture. But I'm not going to start telling people not to do horse riding and not to go running. It's sort of anecdotal evidence in that it's not causative, but it's just some people who've got capsular contracture, they look back and think, oh, these are runners and horse riders. And there's a bit of blood around the implant when they went back to do the capsulectomy. So but if you've got capsular contracture, apart from removing and replacing them, what else could you do? No, I don't know of anything actually on this one. But I would say that if you do replace them, and especially if you've had them on 2 occasions, I would really worry that you're going to get it again. So I would think, goodness me, do you want to go through this again? So first of all, my first advice is leave them as long as you can. And my second thing is, do you want another set of implants? because if you've had it on tour, if it is capsular contracture, you've had it twice now. Every time you do surgery, you create more scar tissue, so you've got a higher risk of capsular contracture every time. So you've got high, it's a vicious circle. It's horrible. And if they didn't have polyurethane, I'd say go polyurethane. But if you've got polyurethane already, I think, oh God, consider whether to have implants at all. The other thing is, if it's not capsular contracture, if it's just pain, it might be the polyurethane implants. It might be causing the pain. Like this patient, in this case, I removed the implants and she was pain free. But then obviously you don't have implants, so. But whether it would happen with a different type of implants, I don't know. It's a one that you need to talk to. That's a proper consultation one. That one, difficult one. But the question for the viewers: is there another way of reducing the chance of capsular contracture? There's lots of things we do to reduce the chance of capsular contracture, but from your point of view, not really. Just stay healthy, be positive, and put up with it for as long as you can, because it's going to come quicker second time around. But there's not a lot you can do as a patient, as I say about the horse riding and running. But I don't really think that's spray tans as well. Spray tans prior to having surgery. It's too late for you because you had surgery, but it's one of the things we don't ask people to do, spray tan before the surgery, because there might be little bugs in the spray, and it could subacute infection, so not proper full-blown infection, but little mild infections can cause capsular contracture. So that's why we asked not to spray tan before surgery. Anyway, yeah. What's going on here on the side? Thank you, double thank you, Jan. Yes, my surgeon said it's not safe to do at the same time. Exercise isn't touching it. 5 stone loss. Whoa, nice one, Jan. Yeah, well, I agree with your surgeon. I think it's a lot of people wouldn't lipo the upper abdomen at the time of a tummy tuck, so it's not unusual for surgeons to say that. I appreciate you answering my question. Thumbs up. My surgeon said revision at 9 months ish. I will continue to exercise to try and help it too. Yeah, do that, Jan. But if you lipo might be a thing that you could do on that. But yeah, do continue. 9 months is a good time, I think. Can't hear you. What? Can't hear you. Helen. Hello, mic number one. I'm assuming people cannot. Jan can hear me because I said I appreciate you answering my question. Hi, Helen. Can you hear me? Helen, can you hear me? Helen, are you there? Right. Well, or is it can't hear you? Here. Anyway, I can hear you very low. No problem with sound. Okay, I can hear you loud. Right. Okay. Whew, bit wide there. Everyone can hear me. Okay. Maybe if I do this, is this better? And riders and runners. Okay. That's better. Right. What is capsular contracture? Oh, Helen, sorry. Am I using terminology that I haven't explained? Capsular contracture is scar tissue that forms around forms around any implant. And got a breast implant show. When you put an implant in the body walls it off with scar tissue. That's normal. That's what the body does. If you get a bit of shrapnel in your arm, or if you put a heart valve in, or a knee replacement, or I don't know, some kind of implant in the body, basically, it walls it off with scar tissue. The problem with and over time that scar tissue contracts. The problem with implants, they're squidgy. If you put a hard thing in, like a heart valve or something, it's not squidgy, so scar tissue forming around it won't compress it. But a breast implant, scar tissue forming around it compresses it, and that scar tissue contracts and makes that squidgy implant into a really hard ball. And when you go to theatre to take it out, and so that's why people say you have to have implants changed every 10 years. You don't have to have it changed every 10 years, but after around 5 or 10 years, they might start to go hard, and you might want to have them changed. And it's usually due to capsular contracture, this scar tissue forming around the implant, making them feel hard. You take them out, you get this hard ball out, you open the hard ball, and there's an implant in there, which is fine. The implant's not a problem. The problem is the scar tissue that's formed around the implant that's gradually contracted over the years and made it feel hard. So that's capsular contracture, and it's a real problem for breast implants, because it's a reason you might need further surgery in the future. Okay, so that's capsular contracture in a nutshell. So can I hold on a minute? Where are we up to? Right, we're up to this one. Can I get some advice on the excess skin on my hips and flanks? Yeah, this is someone who this was the message on Facebook Messenger. That we got no context here. Can I get some advice on the excess skin on my hips and flanks? Well, hips and flanks is a good area for lipo. So normally when you talk about excess skin, I think about cutting it out. But actually, there are some areas where the skin is thicker than other areas. And so the hips and the flanks, the skin is thicker than on the abdomen. For instance, the outer thighs, the skin is thinner than the inner thighs. When we take skin grafts, we always take it from the outer thigh rather than the inner thigh because the skin is thicker. Digressing there, but because the skin is thicker, it recoils better. So, for instance, the hips, the flanks, the outer thighs, they respond well to liposuction. The inner thighs don't respond so well to liposuction because the thin skin's thinner, and you do lipo and you get this redundant skin. That's why you often need a thigh lift because a thigh lift addresses the inner thigh rather than the outer thigh. So yeah, in answer to your question, some advice on the excess skin on your hips and flanks. It's probably skin and fat. Probably, I mean, you might have rolls of excess skin, but if it's skin and fat, then liposuction might be an option for that because, as I say, often the skin will recoil, and so you don't often need to do skin excision for hips and flanks. So Holly Sparkle Hill, what a name, Holly Sparkle Hill. Please, can you tell me how risky it is to have teardrop shaped implants then moving out of place? My surgeon said teardrop shapes would best for me, but I'm worried about them rotating or feeling really fake. Yeah, the main problem with teardrops is the rotating rather than feeling really fake. I think feeling really fake is sort of not so much of a thing, but yeah, rotation is a thing with teardrop implants. So that is the problem with teardrops compared to round implants. It's less common if you're having polyurethane. Polyurethane are much less likely to rotate than silicone implants, but yeah, which would be best for me? I think it's really important to go with the shape that you want, and I think if teardrops is going to be best for you, then go for teardrops. Particularly if you're very slim and you want a natural result without too much fluid in the upper pole. If you haven't got much breast tissue, then teardrops really come into their own. And so it's a balance, isn't it? You want to get the look you want. You don't want it to rotate, but you want to get the look you want. So I wouldn't go with an implant with like a round implant and get it not looking the way you want it to because you're worried about getting a potential complication which might not happen. So yeah, it's a balance, Holly, and it depends on how. So I would probably go with them, to be honest, if your surgeon's saying you're going to get a better result with the teardrop and that's what you want. But you'd have to just go in eyes open and say, yeah, there's a risk. There's risks with everything, and there is more of a risk. There's obviously a risk of rotation with teardrops. You don't get the round, but if that's going to give you a better shape, that's the whole point in doing the surgery. Otherwise, don't do the surgery. No risks then, but you don't get the result you want. So, I wouldn't go halfway house and get a lesser result for less risk of complications. I'd go with the result you want because it's not like it's a huge risk. It's just, an extra risk. Mine's not like that. Mine's gone really soft. That's good, is it, Helen? That's good. It's gone soft, I think, rather than hard. I think that's good. We want them soft. Zoe, after an 8-stone loss, wow, 8-stone loss. Tummy tuck and lipo to flanks. What would you advise for the wobbly back of my hips? Tummy tuck and lipo to flanks. Wobbly back of my hips. Back of my hips. I'm thinking back of my hips is sort of flanks. I'm thinking flanks, sort of like where your kidneys are, sort of around the back there. Liposuction probably. As I say, liposuction works well in those areas. So yeah, if I've got the area right, I'd say liposuction would be probably the way to go. Elaine, my uplift numbers by you. Still love them. Elaine Bowman. Oh, thanks, Elaine. Nice to hear. Don't see you anymore. Come to clinic if you want. Nice to see you. It's good to hear, though. It's lovely. Thank you. Thanks for that. Holly Sparkle Hill. Thank you. Right. So what do we got here? We've got a question here. Where is it? Right. This is a good one here. This is a good one. Does the pubic hair move up when having lipo to the mons? So here we go. I am booked for tummy tuck, breast lift, and lipo to flanks. My question is lipo to the mons area a good idea to have at the same time? I do have a pouch of fat there. Just concerned the pubic hair would then move up too far if it's worked on. Or is there something else that causes the hair to move up? Just asking because I've heard women talk about the hair being in their scar, etc., and being an issue for them. Yes, it is. And this is why I always say to people, you've got to be a bit careful with what you do with the mons at the time of a tummy tuck, because, and it's really good that you're addressing this before having surgery, because you've identified the problem. People who have a tummy tuck often don't realize the mons is quite full. You do the tummy tuck and there's a big mons there, and they're like, what the heck? And you're like, well, that was always there, but it was sort of hidden by the apron of the tissue. And lipo doesn't make your mons move up. So so in answer to your question, does the pubic hair move up when having lipo? No. Lipo will not make the mons move up. So lipo is fine. So if you're just having lipo to find mons, it's fine. And the main thing, but what you're talking about is a thing about the mons being pulled up, the pubic hair being pulled up, and it looking wrong, and you can get clitoral lift, which can actually be quite uncomfortable if you try and move the mons up too much. And that's when you excise mons. So it's a bit like what I was saying earlier about the lipo just removes the fat and doesn't do anything to the skin. If you've got a very prominent, a very ptotic mons, or a sort of big pouch of a mons, and you just do lipo and it doesn't really take any skin out. If you have to start taking skin out and taking a wedge of skin out of the mons and lifting the mons, then you can lift the pubic hair up. And this is why I always say to people that it's limited as to what you do to the mons at the time of a tummy tuck, because a tummy tuck, you're pulling all the tissue down. You're putting it all down. You want the scar to be as low as possible. You want that lower scar to be set where it is, and then you pull the upper scar down to meet it. If you start guddling about and taking some mons out and going down south, then and you release the mons, then the mons can lift up, and then you get the clitoral lift, you get the pubic hair moving up, and it doesn't look right. The look doesn't look good. So I would be very cautious about having any excision of the skin and that mons area at the time of a tummy tuck. So for this, don't worry, because if you're just having mons lipo, that's okay. Mons lipo will not remove that mons up. Mons lipo is okay. It's when you start doing excision of the tissue of the mons that it can lift it up. But if you've got a very ptotic mons, you might need excision, but I would always say it's better to do it later. To have the tummy tuck, get it healed, get that scar anchored where it is, and then you can go down south and bring it back to the anchored scar. If you do it at the time of the tummy tuck scar isn't anchored, it's mobile, and so it'll move up. Does that make sense? So be careful about what. First of all, great that you've recognized you've got a problem with the mons, or the mons is full, so you're not disappointed afterwards, so you're realistic about your expectations. But it's wise just to go with some lipo to the mons at the time of a tummy tuck, and if it's still too ptotic, too much skin there, you could always have an excision of that skin, but it's better to do that later rather than at the time of the tummy tuck, because you don't want it the high hairline and it looking wrong. So that's usually when you have an excision. Hope that's not too technical. Just going to put that up just for a minute. Yeah, just put that up there. Yeah, thank you. Right, risk of it. So this is a big, long. This patient's had loads of problems. She's had lots of implants and had them taken out and put them in, and seen lots of different surgeons. And my feeling is like, do you want any more surgery, to be honest with you, because you had so many problems. But anyway, I think the question that I said I'd talk about here, and I don't know if you can always chip in, but the question I talk about here is one of the issues she had. Well, I'll read it here. However, when deciding all this, he said, this is the end of the email, he said there was some doubt about polyurethane implants causing ALCL, in brackets lymphoma, and offered me new lightweight implants in their stead. He said he would put me on a drug called accolate, which is thought to help with encapsulation. He also told me the ALCL is very rare, 1 in 80,000, but was a slight concern against polyurethane. I am in a quandary as to what to do. All my problems were with encapsulation, and having found a willing surgeon who has successfully removed all my awful scarring, but I now have to decide between the small risk of ALCL or the much bigger risk, for me anyway, of encapsulation. So basically what this patient is saying is they've had problems with capsular contracture, all sorts of problems. They've said all these polyurethane foam implants, they're really good, they're really furry, they've got the foam on the outside, and the tissue grows into the foam, and therefore when it contracts in all different directions, so it doesn't contract like a shell around the implant. And so they've got a much lower rate of capsular contracture. Isn't that great? So if you had loads of problems with capsular contracture, polyurethane implants are really good. It's got a much lower rate of capsular contracture, and that's like a godsend for people who've had problems with capsular contracture. But then this ALCL has come out, And ALCL is thought to be, we don't really know what causes it, but thought to be due to the texturing or the roughness of the implants. And of course, polyurethane implants, their main thing is that they're rough, they're foam, they're much rougher than smooth implants. So that's why France, if you heard, France have banned all textured and polyurethane foam implants, and they're only using smooth implants. Now, I have to say, the implants that you have been offered there, which is she said the lightweight implants. The lightweight implants, these are B-light implants, I suspect, because they're the only lightweight implants they do. And B-light implants are textured implants. So, they also have a risk of ALCL, the textured implants. And this is a really interesting thing now with this ALCL and people moving towards smooth implants, because, and on the face of it, if you said to someone, do you want to have the implants that can cause cancer or not? Everyone would say, not. I'll have the smooth one, please. I don't want polyurethane. I don't want textured. I want the smooth ones. Get away from me with those awful cancer-causing implants. They're terrible. And I can totally understand that. And if people say that, then that's fine. You can have a smooth implant, no problem. Having said that, we still do offer polyurethane and textured implants. You might say, what? You offer these cancer implants? Terrible person. The reason we offer it is because it's about having informed consent and realizing what the risks are, because there are risks with both of them. There are risks with having polyurethane ones, there are risks with having textured, and there are risks with having smooth. Now, the risks of having polyurethane / textured implants of getting ALCL is very small. Not only that, if you do get ALCL, if you're one of the 10, 15 people per year worldwide, it's very small, the numbers of people who are diagnosed with ALCL, it is treatable. Most cases are treatable by removing the capsule. So it's a treatable cancer. It's not like breast cancer. Breast cancer is a bad cancer. Breast cancer happens in 1 in 8 people. This is 1 in 30,000, 1 in 50,000, and it's got a very high cure rate with ALCL. So there was a study a while ago talking about the risk of dying with having implants in. The risk of dying is something like half the risk of living in New York for 2 days or going skiing for a week. You would have no qualms about living in New York for 2 days, having no qualms about going skiing for a week, but your risk of death by doing those things is twice your risk of death with having textured implants in for life. So you've got to balance the risk. Yes, there is a risk, just like there's a risk if you go and drive on the motorway that you might die, but it's very, very small. And you've got to balance that against the benefit. And we've got to balance risks and benefits every day of our lives. Every time we, put the cooker on, every time we get dressed and walk across the street, we're balancing risks, and we could die by the things that we are doing, but the risk of it is very small and the benefit is enough to take that risk by the fact that you want to get to the other side of the street, or you want to go skiing, or you want to go to New York, or you want to drink a glass of wine, or travel on the M42 or whatever it is. So there's risks with everything. So you've got to balance those risks. And the problem is that if you is like with light, then fine. But smooth implants have got their own problems. Smooth implants were the very first type of implants that they made, and then they progressed by making them textured and polyurethane. By these are advances of implants to make them less likely to cause capsular contracture, less likely to move. The texturing makes them less likely to move. And so smooth implants, you can't get teardrop, forget it. They don't, because they just wobble about all over the place. So and recently this has happened recently to me, because I've recently just had a patient who has had an implant flip on itself. And this is only something I've only ever seen once before, and I thought, wow, this is a round implant, so it's not a teardrop implant, and it's flipped in sort of that direction, so the back has gone to the front. I thought, wow, that's uncommon. I haven't seen it before, years ago. Crikey. And then what happened? She phoned up a few weeks later, and the other ones flipped. They both flipped. Fortunately, I haven't taken back to theatre to unflip the first one. So they both flipped. And I'm thinking that these are brand new implants. And I'm thinking the implants are becoming much less textured now, because we're worried about ALCL. But when they're not so textured, they're more likely to move and cause different problems. Now, you might say, oh, crumbs, I can cope with flipping, I don't want ALCL, but it's just that the risk of ALCL is so low, you've got to be careful and just be informed about whether if you do want smooth implants, they are, the first generation of implants were smooth. They were the sort of base back in 1960s. That's how they first made them. And the texturing and the polyurethane, all that sort of stuff were advances for a reason. And there are good things about texturing. There are good things about polyurethane. And so we do offer all of them to patients still, because it's about weighing the risks versus the benefits. So I know this patient's got a huge risk of capsular contracture. So she's got to weigh up the risks herself between the risk of capsular contracture by having these lightweight implants, which are actually textured silicone implants, versus the risk of ALCL. But I understand it's very emotive ALCL because it's cancer, and it's that's a terrible thing. But it's a curable thing and it's very rare. But still, at the end of the day, you have to balance it up. And Elaine, love you, Elaine, saying she's got textured implants and she's happy, and I'm happy too, Elaine. Sparkle Hill is in. How is ALCL detected, please? Great question, Sparkle. So it is a swelling or a lump. And it usually occurs sometime after having implantation, like about 8 years after implantation. So if you get a swelling or a lump, usually unilateral, i.e. one side, you should go and see your surgeon. To be honest with you, we'd say that anyway. Like if you got a swelling or a lump, come and see me, but certainly nowadays, because it's only a recent thing, ALCL, nowadays it's one of a swelling or a lump, we think, oh, ALCL. And it's usually I offer everybody yearly follow-ups. Elaine, come back and see me. I offer everybody yearly follow-ups. They don't have to come back every year, but I offer it to everybody. But it's usually picked up by the patient. So it's something the patient will usually pick up. So if you have a lump or swelling, the advice is go and see your doctor. You don't have to panic if you haven't got any problems. If you've got textured implants in, if you've got polyurethane implants in, there's no problem. You don't need to do anything. You don't have to have any scan or test or anything like that. But if you do develop a lump or swelling, you need to go and see your doctor. To be honest, you need to anyway. Lumps and swellings we worry about with breasts. Breast cancer is far more common, and something we really need to be worried about. So we need to be looking for lumps and swellings in our breasts anyway, because but that is how it's detected, usually by the patient. Roseanne is in, because I was going to say that was the last question, actually, Roseanne. So this is the last question now. Roseanne's got the last question. Well, unless there's another question after, in which case you'll have the second to last. What's the best way to prevent infection after a TT? Good question. Like it. So there's things that we can do and there's things that you can do. So things that we can do is we've got to be careful with the attention, be careful how tight we make it, be very careful with our tissue handling, keep it clean with dressings, what have you, although you only need dressings for a week or so. Dressings aren't as important with infection as you might think. For your point of view, Roseanne, what you need to do is you need to stay positive. You need to have a positive mental attitude. I don't want to get weirdy beardy. I don't want to get spiritual, but I think it is important to be positive and, don't focus on the badness. If you are worried about anything, you need to seek help early. Don't worry too much. Infection is not normally a big problem with tummy tuck. It can be, but it's not normally a big problem with tummy tuck. But if you do notice a bit of redness, bit of pain, bit of discharge, then go and seek help early. You need to take it easy. You need to not be doing exercises and things like that. Don't want to be putting tension on your abdomen. So take it easy. When you first have it done, you'll be bent double. Just taking the tension off your abdomen. You need to eat healthily. You've got big wounds. Tummy tucks are massive, great big wounds. Eat healthily, fresh fruit and veg. Drink plenty. Don't smoke. Number one, don't smoke. I'm not saying you do smoke because I don't know, but if you do smoke, for goodness sake, don't smoke. To the extent that I don't have a problem with smokers, there's no problem at all. If you want to smoke, that's absolutely fine. But if people smoke and they need a tummy tuck, I would say to them, don't have a tummy tuck. It's that bad. Don't have a tummy tuck. If you can't stop smoking, don't have a tummy tuck. Same with a mastopexy, same with a breast lift. All these surgeries, same with a facelift. If you have to, all these surgeries rely on everything being closed tight. That's the reason you have the surgery. And when it's closed tight, every time you have a cigarette, you reduce the blood flow to your skin and you increase your risk of wound breakdown. The only really big wound breakdowns I've ever seen, I think I can say this, have been in smokers. Now, that doesn't mean that all smokers get big wound breakdowns. But if you see a really big bad wound breakdown, the first thing you think is it a smoker? And so that's the big thing. Don't smoke. Stay positive. eat healthily, take the tension off, stay close to your surgeon. Any problems, any bit of redness or anything like that, get help, but don't worry about it. It's, you know, it's often okay. Sometimes you get little bits of wound breakdown, little bits of stitch spitting out, not really proper infection, just a bit of redness, a bit of inflammation. But yeah, great live, Jan. Yes, smashed it. Holly, great live, double great live. Elaine, I'll be booking consultation regarding a thigh lift. Great live. God, look at this. Got business out of it. Fantastic. Fantastic. Looking forward to seeing you, Elaine. Well, thank you for that. And great to be back. I missed it last week. I tell you, I missed it. Great to be back. I'm going to sign myself off now. I'm signing myself off and I'm going to go and have a lie down. And see you next week. Any questions, ask them, please, on Facebook or somewhere else. I'll find a thing that says, oh, look, oh, Helen's in with a late one. I used Annika to heal. Annika. I think you mean arnica. Is it arnica? Arnica is supposed to be good for bruising, isn't it, Helen? Yeah, a lot of people say that. I wonder if we should say it at the clinic. I'm not sure whether there's evidence on that, but a lot of people say arnica is good. The thing I do find, Helen, though, is that often you don't get much bruising anyway. So that's why I don't really go heavy on the arnica, because I don't see bruising as a major thing in most of my patients. Sometimes, occasionally, you get a bit of bruising, but it's often not a big thing. So sometimes people say, oh, look at that, I've used arnica and I've got no bruising. And you're like, well, don't normally get bruising, but you know, I don't want to knock it. I don't think it does any harm. So that's the main thing. So yeah, but there's big up arnica. I'm assuming it's arnica, Helena, not actually Annika. I'm going to Google Annika now and find that it's actually something totally else. Something else. Roseanne loves listening to me. Thank you. That's kind. It does mean thanks. Something. Thank you. Great to have you, BK. Look at that, Zoe. You can't even write back. Let's abbreviate back. BK. Thanks for having me, BK, Zoe. And that's it. Oh, that's arnica, I think. Yeah. Okay. So good night. And I'm not going to say God bless. It's like Bruce Forsyth. I'm trying to say the thing is, please ask a question, but I can't find it. Anyway, let's just assume something down there says, if you've got any questions, ask me. Put it on Facebook or something. I don't think I've got a thing that says that, actually. I thought I did. Anyway, checking myself out, and next Tuesday, 7 p.m. right here or somewhere. Jan, I am going to go and get a cuppa. That's exactly what I need. Go and get a cuppa and a lie down, and I'm going to read my book. All right, then. Thanks and good night. See you next week. Bye.